Myself, Dr. Jasmeet, a member and a certified metabolic health coach from DLife.in. So DLife, which is India's first and the only award-winning low-carb platform. DLife was founded in 2014 by Anup Singh. Anup is also a silver medalist from the prestigious institute IIT Roorkee, and the recipient of Icons of India Award. Anup is the pioneer of the low-carb movement in India with his path-breaking protocol of 100 gram carbs per day max that made LCHF possible for even the Indian vegetarians and helped them put their diabetes in remission. In
Awesome. Yeah.
2021, DLife launched its diploma course, which is the only course approved under the NST's partner, the Government of India in this segment, and the only course with the global biggest 144 hours CPD hours credit. So we have Anup here. So he's also the co-organizer of this conference along with Shashikant Iyengar. So let me now take the pleasure to introduce our esteemed guest, R.D. Dikeman. So R.D. Dikeman, he is a Ph.D. in theoretical physics, and he became interested in the therapeutical low-carb nutrition to manage the type 1 diabetes after his son was diagnosed with this condition at age 9. So post-diagnosis, the family faced significant challenges with the blood sugar management as a standard treatment method. They were taught like carbohydrate counting and the insulin coverage that was ineffective and led to the erratic blood sugar levels. So while searching for the solution for the problem, RD's wife, Roxanne Dikeman, she discovered Dr. Bernstein's book, The Diabetes Solution, which provided the clarity and reassurance about their struggles. So this discovery completely transformed their life, and then further driven by the desire to help others, people facing the similar challenges, RD launched the Diabetes University YouTube channel along with the Dr. Richard Bernstein, aiming to bring his valuable insights accessible to all. So he then also founded the TypeOneGrit community on the Facebook, offering a supportive space for families to share experiences and connect with each other while navigating the complexities of the type 1 diabetes. So welcome again, Dr. Dikeman.
Thank you. Yeah.
So
welcome, Dr. Dikeman. And what a coincidence. There are two physicists on screen.
Yeah.
Oh, great. I didn't know that about you. I follow you, but I follow you guys. You guys are great. Yeah. But I didn't know that. That's interesting.
Yeah. Dr. Dikeman.
Jasmeet is PhD nuclear physics, experimental nuclear physics.
Yeah.
Okay. Oh, Jasmeet. Okay.
Yeah. So Dr. Dikeman, actually, Anup, he is not the co-organizer, just not the co-organizer. He's also my teacher. Basically, he introduced me to the Dr. Bernstein's approach back in 2016. So
fantastic.
Yeah. So basically, he is the one who's teaching all of us the Dr. Bernstein's approach through the DLife forum. So, okay.
Gotcha.
So let's now start with the first question. I think we can start with your personal experience as a parent of a child with type 1 diabetes. If you could please describe how all this situation began, including the initial symptoms that led to the diagnosis.
Yeah. Okay. Yeah. So if you're a physics person, you might enter the world of diabetes and nutrition knowing absolutely nothing. You know, physicists are not the best source to go to as far as nutrition goes. We have things like cookie hour every day where we discuss physics, but we eat a bunch of junk food. So, and like a lot of people, when I entered the realm of the type 1 diabetes, I didn't know anything about diabetes. I didn't know if insulin brought your blood sugar up or down. Why on TV you'd see shows where people with type 1 had to have candy. All that stuff was sort of a mystery to me. I never bothered learning anything about it. I never met a single person with type 1 diabetes in my life. And I was like a lot of guys from the United States who are from the Midwest. You know, I liked pizza, I liked beer. I was, you know, in my 40s, a little bit overweight. And suddenly I had a sick 9-year-old, and you know, like any parent, you're used to your kids being sick all the time, so it's not a big deal. And you know, our diagnosis story. Well, I could tell a long story about this, but I'll keep it short. Our diagnosis story is not unusual. There are some people who are on the ball and they catch things early. But with Dave, we didn't. And a lot of people don't. And the thing I want to convey to people is that type 1 diabetes, the autoimmune attack may be occurring in the background for a few months, but when it really strikes, the action of the diabetes is such that you fall off a cliff. And so with Dave, we had a football game on a Saturday, and then by the next week, we were in the hospital, and I can't. I want to share a picture, but I don't know how to on Zoom. I'm not a Zoom person.
You can share.
Just
somebody has to authorize screen share.
Okay. Yeah. Okay. Well, I can show you a picture of Dave. He looks like he's been in a concentration camp. He probably lost 20 or 30 pounds as a 9-year-old in about a week. So this is not something that you have a good sense of what's going on, and you just things happen so fast that it's extremely dangerous, of course. So you really have to be on the ball, of what's going on. So I'll say it that way. If you follow my Facebook page, there's some pictures up there of Dave in DKA, and he looks like he's near death, and it caught us off guard. He was sick. He was laying around in bed. We just said, well, just take a few days off of school. You're not feeling well. And then he had a moment where I had to help him. He couldn't get up, and I helped him take his shirt off, and he was a skeleton. And this happened so rapidly. I still have trauma about it. It was a nightmare. So, when type 1 strikes, it is a catastrophic, we talk a lot about type 2 taking decades to start up. Type 1 may be in the background, you might not detect it, and all of a sudden within a week, your kid can die, and kids do die. Yeah, it's a very serious condition.
Yeah, was it DKA? Because type 1 are especially prone to DKA, and that's how.
That's right.
Yeah,
that's right.
That's how.
So type 1, okay, so yeah, the basics of the physiology, he was no longer producing insulin. And when you no longer produce insulin, you can't get any energy into your cells, and the reaction, your metabolism is off, let's say, and your body, your liver and your peripheries just spew glucose and then spew ketones, and your blood sugar goes up to a gazillion. Your A1C, if it's been going on in the background, can be 10, 14, 16. These are catastrophically high blood sugars that are occurring, and what happens to the person is that they eventually succumb from dehydration and brain edema. So you got to get insulin into these kids as fast as possible, or else they die. And that's what happened today. We made it to the emergency room. He was probably a few hours away from dying, and the doctor came in and was talking to Dave about sports, and I said, "Why are you wasting this time?" And she said, "Because I've never seen someone with such high levels, and we need to make sure that Dave's brain is okay." So she was asking him a few questions, and he was fine, but anyway, it took a long time to get him back to proper shape, and that's kind of where the story starts. It starts off as a typical story, and then we hit the part where Dave was put on a diabetes industry path, and with a high carb, high insulin diet, and that's where the real story begins.
Yeah, Adi, you can try screen share now. You're authorized to share this. Yeah.
Yeah. What do I do?
You can share the picture of your son, like you mentioned.
At the bottom of the screen, you will find share. So you can share your screen.
All right. I'm looking. Oh, there it is. So my window is too small. Okay. Here's a picture. Let's see. Can you see it?
Dr. Dikeman, if you can also talk a little bit about the role of insulin, which is not just to regulate the blood sugar, but also it's an anti-catabolic hormone, like why the kids, they get into A, so that the people understand.
Okay, so
The
yeah,
sudden weight loss happened.
so we can get rapidly into the interesting technical portion, so we can bounce around. But my we had a good question for the endocrinologist, which was Dave. Dave said when we were discussing with the endo how blood sugar and type 1 works. And the idea from the diabetes industry is you count up the carbs you eat and then you take a proportional amount of insulin and you hope that those things balance so your blood sugar works. And of course, the reality of that is it never works. It doesn't work for anybody, this carb counting method, but they keep pushing it. But Dave was smart and he said, "Well, why don't I just stop? I just won't eat carbohydrate." And the initial reaction from the doctor was kind of laughter at him, and I laughed a little too, which is you need carbs for energy. But first of all, you don't need carbs for energy. But then the question then is, which we didn't respond to, was, well, if he does remove the carbohydrate, maybe he doesn't need any insulin. And the reality is for type 1s on a very low carb diet, we we expose the need for insulin for many metabolic processes. So you need insulin to metabolize protein foods. You need insulin, you need a background layer, a level of insulin. You need insulin. Insulin is a governor of lipolysis. So there's many processes involved. It may not, you can even justify the concept that insulin is not, the chief role of insulin is not to move glucose around into the cells. Now, with type 2 diabetes, insulin resistance is properly held up as a big problem. And it is, because you don't want super industrial doses of insulin floating around in your body. But we also, with the type 1, you don't want zero insulin. And all macronutrients are involved with insulin metabolism. So the type 1 diabetic has to take insulin, like Dave. He doesn't eat any carbohydrate or very little, but the insulin that he does take is used to cover protein foods, and we can talk about why, and then the background basal rate. When we did this, I'm going to skip around a lot. When we did this paper much later, this story of Dave, and we gathered many other people who are having the same experience. We did a paper with some Harvard researchers, David Ludwig and Belinda Linares, and many other people. Dr. Westman was on the paper, Bernstein was on the paper, I was on the paper. We found that the insulin dosing for the type 1s came down by about half. So you'll hear this a lot. When they go on a low carb diet, when they go on a carnivore diet, their insulin levels plummet. It decreases by about half. And the reason why it's non-zero is because when you remove the carbohydrate, most of the insulin dosing and the problems of type 1 are about covering protein foods. And it just happens that the physics of injected insulin, because you're not producing anymore, there's no feedback loop in your body. You're guessing at the meal and you're giving yourself a shot. The physics of injected insulin dictate that with protein, which is a very slow acting glycemic effect, the protein isn't turning to glucose. You're taking insulin to prevent the protein from turning into glucose. But when you cover that protein, the physics dictate that you're able to withstand a lot more error and keep your blood sugars right around normal than you would if you were trying to bolus for this rapid acting carbohydrate that everyone tries to eat.
So,
So
Dr. Dikeman, what we can do is we can start with the high carb, low fat diet.
Yeah,
Which was the
here's a
first
nice
piece of
picture.
advice you got from your doctor.
Yeah. Okay,
And
we'll
what was
skip
the
around.
point, like when you we can then switch to the high protein diets, and let us first start with the high carb, low fat, so that the people understand why that piece of advice doesn't work for you.
Yeah, look at this
And in
picture.
general as well.
We tried to do the right thing and follow the diabetes industry protocol, which is eat foods like, we were big oatmeal eaters. Dave loves Starbucks chocolate chip cookies. And I thought I was smart enough to figure out how to cover these foods with insulin. And look at our results. You can't read the y-axis, but it goes from 50 to 400, basically. Is there any pattern in that data? I mean, the the program tried to draw a line through the data, but there's no line that should be drawn through that data. What I was seeing was what I would call in mathematics a stochastic result, meaning that there are things going on that are deterministic, but the results coming out of the box is basically random. And I couldn't figure it out. There was no way to cover carbohydrate. After about 2-3 weeks of trying to do this, I realized that Dave was in real trouble. And let me show you why. Because simultaneously, when I was trying to figure this out, I started to do research on what's going to happen to Dave. And what I found was that Dave's life was going to be ruined because not only would he die early, every organ in his body would be destroyed over time. So while he was losing 10 to 20 years of life, he would also be experiencing what are called diabetic complications. And that means pick an organ, your brain. The brain is, we can already see the brain damage in type 1 kids who have had elevated blood glucose. The kidneys, the eyes, every single organ in the body, and some organs more rapidly than others. The ability to have an erection if you're a man, it goes on and on, and it was a terrifying read of the literature, and it's so terrifying. I can understand why people close their eyes and don't even want to hear about it. They just think, hopefully there's going to be a cure because we're doing everything a doctor is telling us to, and it's not working.
So basically, you started with a high carb approach, which was a standard advice given by your doctor.
That's
So
right.
then you try to fix the most of the variables like the carbohydrates, protein, and the fat in the meal. And then you try to figure out the insulin dosages. So you showed the graph, like, every time
Yeah.
you fix the meals, the different number of variables, still your results it was like a stochastic.
Yeah. I like that word, stochastic.
Yeah.
Because
So
I recognize that with this curve, there was something pushing it up. There was a forcing function and there was a decay, and I recognized that there was some mathematics involved. So I was trying to get my head around the mathematics. But what I realized was that this system was not going to allow for that.
If I can interject, I saw that graph. Can we go back to the graph, please? The chart.
Yes. Let's blow it
this
up.
one.
Yeah.
Now, I think you would agree that in blood sugar control, especially if it is type 1 diabetic, where you have to be very cautious 24/7, there are two things which one has to look into. One is getting the levels down, and second is minimizing the excursion, because every excursion is associated with some damage.
Right.
I have seen many videos. I think I saw you and your son's video on Dr. Bernstein's channel, that Diabetes University. You were there, right? In one interview, I think I've seen you, your son.
Yeah.
So that is, that is how even I landed on that YouTube channel. And yes, he says, small portions, small numbers. That's his theory.
Right.
Theory of small numbers, right?
Yes.
So basically 6, 12, 12, he talks something on 6, 12, 12 carbs.
That's right.
And and that primarily he says, that aim is twofold. One is to keep the levels low, and second is to minimize the excursion.
That's right. Yeah.
So
can you talk about this law of small numbers, Dr. Dikeman?
Yeah. So the law of small numbers is like, the law of thermodynamics. There's like three laws, right? The law of small numbers is kind of one of those laws. And it's a simple enough law that's the one that gets a lot of attention. But if you look under the hood about what's happening with insulin, it's not just the quantity that's lowered, because as I mentioned, the people in TypeOneGrit, they're lowering their insulin dose by about 50%. Also, you have teenagers in TypeOneGrit, and teenagers have a lot of growth hormone and they're eating a lot. So their insulin levels are very, very high. We have teenagers in type 1 grit who are taking much more insulin than people who are adults on high carb diets. And the teenagers have the flat line. And the adults who are eating carbohydrate are all over the place. So that seems to be defying the law of small numbers. How can, like Dave was taking over 100 units of insulin a day when he was 15. And you might have some type 1 diabetic who's on a high carb diet, who's 50, 60 years old, doing 20 units of insulin. But Dave had superior numbers. And the question is, well, what's going on there? And the answer is, it's more about the rates. It's technical. It's not about just the quantity. It's about the rates of insulin absorption. It's about the rates of the glycemic excursion of the meals you're eating. And when you eat a steak, let's for sake of argument say, well, we have a 16-ounce steak in front of us. Dave is going to take about 8 units of insulin. It's about 1 unit per 2 ounces. Okay. That's a lot of insulin, 8 units. But the kind of insulin he's taking is super slow. And the kind of glycemic excursion caused by protein was super slow. And it's really easy. Even if you don't match those things, you're okay because there's very little difference. And so Dave, over a period of 6 to 8 hours when he's digesting his food, he can correct his blood sugar with a little more insulin or take a little glucose. Every time Dave eats, he has to watch what happens. This is not a set it and forget it situation. But he tries to be around 83, around 4 or 5 millimoles. But if he goes up to 6, or if he goes down to 3.5, he fixes it easily. What about the person who's taking 8 units of insulin to cover a bowl of cereal on a high carb diet? As soon as they take a bite of cereal or 2, their blood sugar goes straight up. And there's no way to cover that with injected insulin, which acts so slowly, right? So it's not just the getting rid of the insulin or decreasing the insulin. People will say, oh, well, you go on a low carb diet and your insulin plummets to 1 or 2 units. Not necessarily true. We have type 1 kids who are taking 50 or 100 units of insulin because they need it. They're eating so much food. They have so much growth hormone in their body, but they have a blood sugar of 4.9. Here's Dave. He's hitting his growth chart. If you can see the PowerPoint, he's hitting his growth peak as like an 8-10-year-old. His A1C is 4.9. He's taking a ton of insulin. So it's really about the insulin kinetics. That's what, and this all translates into a massive quality of life improvement. Because I'll give you an example. Dave was in a very large private school. There were other type 1s. Dave and the nurse's station was across the campus. So to go to see the nurse, if you had a problem as a type 1, you would be driven on a golf cart by the nurse. The nurse would come and get you. It's a dangerous process because it took too long. Dave never took that golf cart because if his blood sugar went low, it was going low so slowly that he could take a little glucose pill that he keeps in his pocket. The other type 1 kid who was always eating carbohydrates, Doritos, the kind of standard American junk food, he was every week, every day, Dave would see him go into the nurse's office. And that's because when you're following the diabetes industry advice, your blood sugar is just like this picture. And this picture, because it's stochastic, it comes not just with highs, but with dangerous lows. And so while we're happy that Dave eventually got to this place, let me see if I can show you Dave's graphs, like in the bottom picture here. I'm sorry, it's so small. This is where he started, and this is where
So,
he
Dr.
ended up.
Dikeman, what do you
Yep.
think? What's the logic behind giving this industrial doses of insulin? So, is it something that they want to make the people insulin resistant intentionally so that the risk of hypoglycemia reduces?
Well, the doctors, first of all, the doctors have no idea how to control blood sugar. So what we have to do is we have to teach the doctors that are willing to learn how to do this. And it's not just the low carb. You need here's I'm going to skip ahead to show you just a slide for, we're not going to go through it right now, but here there's a lot to do what Dave does. You don't just put a kid on a low carb diet and say, well, you're not taking barely any insulin anymore and you're all good. You know, just shoot a couple units of insulin in the morning and go off and you know, it's basically like problem solved. You still have to do all these things and you have to watch yourself 24/7. And if you make missteps in any of these steps, you're not going to get the control that you need. And this is the genius of Bernstein. Is
So, Dr.
Bernstein
Dikeman,
didn't?
what we can do
Yep.
is we can discuss
Mhm.
all these key points one by one. So
Yeah,
the
I'm
first
sorry I'm
one,
jumping around.
yeah, the first one that you mentioned is like the Dr. Bernstein, he recommends a specific carbohydrate intake for all the different meals. Like what you have
Yes.
mentioned is 6 gram for the breakfast, 12 gram for the
Yep.
lunch, and 12 gram for the dinner.
That's
And
right.
the next point he mentioned is like the goal is not just to limit the carbohydrates, but to eliminate some specific type of carbohydrates. So could you please comment?
Yes. Yes. So here you have evidence for what I'm saying about the insulin kinetics and not just the amount of insulin. And so what Bernstein is saying is he started off thinking that with the idea that there's real value in having some vegetable because there's phytonutrients in vegetables. So he said, I don't want to take vegetables away from people. So he realized that if you eat a little bit of salad or some steamed broccoli or something like that. And by the way, for carnivore people, Bernstein maintains that he still believes that the need for vegetables is at the hypothesis level. But let's put that aside. If you're going to have some nuts or some vegetables, you're going to realize that you can eat a lot of vegetables. Like 6 grams of broccoli is a lot of broccoli, right? It's enough for your side dish, let's say. But there's something interesting about vegetables and nuts, and it's that their glycemic action is very similar to this glycemic action of protein foods. And so they can be covered within the context of using these slow-acting intermediate bolus insulins. So he allows it. What about things like berries? They're a little bit faster acting, so Bernstein doesn't recommend using berries. So he has a clear line that he draws. Now, why is it fibrous vegetables and some nuts and not starches or grains or sugars or like a banana or an orange? That's because of the kinetics. It's because these foods rise your blood sugar so rapidly that you have no chance of catching up or matching your injected insulin dose. So remember what I was saying about the steak, right? A steak that a teenager would eat, say a big steak, or a large person like me, 16 ounces, that's 8 units of insulin. That would cover 80 grams of carbs. That's not a small amount of carbs. That's a sizable bowl of oatmeal. So why couldn't I just eat oatmeal instead of the steak? It's because of the rates. It's because when you eat these rapid acting carbohydrates, right, you can't cover them reliably with injected insulin. And that's the whole game, is to get that insulin, that blood sugar level flat and remove most of the stochastic nature of the glycemic response. So that's why no rapid acting carbohydrate.
If I can, ask one follow-up question, which is most important for any type 1 caretaker, parent, or anybody. Now, insulin dosing, as you said, doctors don't know how to control or how to dose insulin. Now,
Right.
in our community, we had three type 1 kids, and you'd be happy to know that the lowest A1C for a 4.5-year-old was 4.5.
Okay,
That
that's
was the
tremendous.
control, right? And we are a low carb community basically. And the other one was, I think, for 4 or 5 years. I think you had commented once on Twitter. For 4 or 5 years, she had been maintaining A1C of 5.0. And you had mentioned that barely 1%, top 1% of
That's right.
type 1 diabetics get there.
That's right.
So now, yeah, the most interesting or most tough point is insulin dosing, which doctors don't teach you. right?
Yeah.
So what is the theory of basically insulin dosing bolus
Yes.
on a rough, estimate, not very precise,
Right.
and basal, and the third one I think would be correcting any unexpected spike.
Okay. So we get into the good details. So
Yeah.
have you ever heard the phrase, take two pills and call me in the morning? That's kind of a famous, that is kind of, so most medications are dosed in such a way, right? You're given a prescription, you take a pill once a day, and that's a very natural thing. The problem with type 1 is not only is everybody individual to a very high degree, but their individuality changes. The child grows. Females go through a monthly cycle. Everybody has this variability. And so what you need to know as a type 1 is not just the dose that you need to take, you need to know how to calculate the dose or how to estimate the dose that you're taking. So you really need to understand the physics of how injected insulin works, right? Some people are going to take totally different amounts of insulin than other people. Okay, we'll put basal insulin aside. Let's talk about mealtime insulin. The general idea for Bernstein is around 1 unit of intermediate acting insulin, which is it's called regular insulin or Humulin R, for 2 ounces of protein food. That's a good starting point, but you may need less and you may need more. So what do? The best you can do is to eat the same meal plan every day. That's consistency. That's on this chart. And that's what Bernstein does. He has a meal plan. If he gets tired of it after a few months, he switches it. But now Dave is in college right now, and you'd think, well, that's so boring to eat the same thing every day. But Dave's busy and he's got a lot of activities to do besides school. So it's very easy for him to wake up, have 3 eggs, and go off on his day. He's not growing anymore and he's not as active. So he might skip lunch. That's okay. But he knows how much insulin to take for that 3 egg breakfast, right? So there's a way to do it, and that's the general. You estimate your initial bolus insulin dose, you develop a meal plan, and you fine tune your dose to that meal plan, and you keep fine tuning it. Right now, if Dave has a heavy exercise load, he knows to give himself different amounts of insulin through experience, right? But these things, they're all knowable. If you're on this high carb diet, it's all
Yes.
guesswork. It's like you're believing in mystical things. So, for example, a typical diabetic on the industry diet will go to their endocrinologist, and the endocrinologist will see their blood sugars like this. And then the endocrinologist will say, okay, let's adjust your carb ratio, meaning how much you're taking 1 unit for 10 grams of carb. Let's change it to 9 grams of carb. And then the next time the person comes in, their blood sugar's like this. It's this game that doesn't work, right? But with Bernstein, you have a good starting point. You nail down your meal plan, you nail down your bolus plan, which is what he does if you go visit him. He puts you on a meal plan for a week and you visit him for a week until he gets your dosing right. Now, what happens if something goes wrong? You mentioned corrective insulin. This happens all the time because we still have a stochastic process, but the the scales are different. So you always have to be watching your blood sugar. It doesn't just automatically stay level, right? Low carb is not just like, well, you barely need any more insulin and you just take a unit in the morning and you're fine. You have to constantly watch and you have to constantly correct. The reason to watch is because you have to correct. So how do you correct? If you're low, you take glucose. Glucose is fastest. You don't take honey or milk or eat food because you can't measure that and it's slow. So if you're it's say taking some honey, it takes a long time to digest honey. And so you may continue going slow until you get into trouble. What about highs? The highs that we're talking about are quite low. Um, Dave, if he goes up to 110, 115, he'll take what's called an intramuscular shot. He'll take a unit of a needle of a syringe off a syringe. The syringe is a little bit longer, and he'll put it right in his deltoid. And if it goes in the muscle, it works faster. So he can bring that 120 down, back down to 105, 90, before it gets up to 140, 180, 200, like you would, sometimes see.
So, Dr.
Right.
Dikeman, if you could please talk about like optimal, which is so important when we eat a high protein diet in order to inhibit the gluconeogenesis. Could you please talk about
Yes.
this?
Okay, so this is a technical myth, but a lot of people believe that the reason that type 1s are taking insulin for protein foods is because half the protein turns into glucose. What you're doing with insulin is you're preventing the protein food from turning into glucose. So what happens, the technical biochemistry is when you eat protein, it hits your belly secretes GLP-1. GLP-1 causes the secretion of glucagon from your alpha cells. In a non-diabetic, that glucagon is opposed at the surface of the cell by a secretion of insulin from the beta cells. But in a type 1, there is no secretion. So what happens? That glucagon goes off into your body. It hits your muscle, it hits your liver, and in your muscle and liver are stored glycogen. Glycogen is a glucose starch. When it hits the liver, it gives a signal to the liver, dump glucose that you've stored into the bloodstream. That process is called glycogenolysis. That's the reason your blood sugar is rising. What's the downstream effect? Your liver is going to want to recharge. You can either shove that circulating glucose back into the liver, or you can convert some of that glucose with enhanced gluconeogenesis rates, which you don't want. You want your protein to be protein,
Yeah.
right? And so I suspect that my suspicion is if you look at type 1s, kids, they all have somewhat stunted growth because of high A1Cs. We don't see that in the TypeOneGrit kids. It's like the opposite. They grow beautifully. I suspect that there's a sort of protein deficiency that occurs because of high blood sugars, because these kids on high carb diets are eating meals that include protein, and a lot of their protein is being wasted by inefficient metabolic processes. That's my hunch. Yeah.
Yeah.
So anyway, your steak is not turning into cake, and that's why you need glucose or insulin to cover protein. It's to govern the possibility that your liver is going to dump glycogen.
Okay. So, Anup, you have any
Yeah, there's
questions
one,
regarding this, like glucagon or?
no, I would like to ask one question, which is very important, and it can be a nightmare for any parent or caretaker for type 1. There's a phenomenon known as death in bed syndrome
Yeah.
Right.
for type 1, right? Can you please,
Yes.
throw some highlight onto it, like what time the monitoring has to be very, very precise, especially.
Yes. So I will say, yeah, let me issue a broad statement about parenting a type 1 diabetic. The first rule of parenting a type 1 diabetic is to never complain about type 1 diabetes. The parent is not the star of the show. You're not the victim. Your child has type 1 diabetes. You don't want to inflict trauma on your child by making diabetes turn into your personal nightmare as a parent. This is not a misery pageant that you're trying to become king or queen of. What you're trying to do is trying to elevate your child's psyche so that they're a champion of their condition and that they feel like they've conquered a difficult situation. So that's my first thing. Now let's talk about death in bed. To me, it's a shock that there's not more of it, because the diabetes industry protocol to shove so much carbohydrate into your kids and so much insulin with the stochastic process, the only way to stop your kid from dying on that diet is to run them so high that they begin to have retinopathy and other complications before they even get out of their teen years, right? So, but what you have to do on a high carb or a low carb diet let's talk about my experience on low carb. From when Dave went to bed to when he woke up in the morning, it was 1, 2, or 3 checks every single night to keep his blood sugar in range. The variability that can occur in a child, a type 1 child, even if they're on a very low carb diet. Look, Dave's diabetes is so well controlled. Bernstein keeps a picture of him and his CGM in his pocket and shows it to new patients. Even though that's true, I have to check his blood sugar 2 or 3 times a night because it can go low or it can go high. And that's just the nature of the condition. It doesn't mean that I'm a helicopter parent. And this is what all parents do who have kids that are getting good blood sugars. The good blood sugars don't come automatically. You have to work on it 24/7. So if you want to avoid your kid having death in bed, I would say do whatever you can to keep their blood sugars as stable as possible. And that means a low carb diet. And then you have to do the work. And you have to do the work without complaint. You're not the victim. Just set the situation up nicely. Put a headlamp in your room, have the glucose ready, have the insulin ready, go in and check. Or if you have a CGM, you can look on your phone if you're feeling like your CGM is accurate. Do the work, be happy about it, be a happy warrior for your kid, be on their team, make it feel like a team process. Your kid's going to go off to college one day or off to work, and you want your kid to call you and say, I just, ran 15 miles and my blood sugar is doing this. What do you think? And if you inflict trauma on them as when they're under your care, they're not going to make that call.
Yeah, thank you, Dave. I think we are nearing, time,
Yeah.
22.
Yeah.
So we can close this screen share and get Shashi in. And
Yes.
it was definitely, yeah.
I think, no, before we close, I have a last question for him
Yeah.
because,
I'll make it brief. Yeah.
Yeah,
Mhm.
because recently the Society of Metabolic Health Practitioner, they issued a position statement regarding the therapeutic carbohydrate reduction for managing the type 1 diabetes. So could you
Yes.
please talk about that statement, that what are the key points, if you can mention very quickly, and how might it can enhance the management of type 1 diabetes globally?
Yes. So this story started in 2014. It's now 2025, and the story has picked up real traction. When I started, no one knew about low carb and type 1. Now everybody knows about low carb and type 1. And the SMHP was the first professional medical industry with, no kidding, real hero doctors. My kids were on this paper as well. And they advocate that all type 1 diabetics are entitled to this knowledge of how to normalize their blood sugar with very low carb, right? Now you have no chance, virtually no chance of being told about low carb or how to normalize your blood sugar. So we're seeing real progress. Doctors are seeing patients that are experiencing these great blood sugars, and we have a real and I guess the hero of this story really is Dr. Tro, who pushed so hard and did such a great job on this, on authoring, being the lead author of this paper. He deserves a lot of credit for helping type 1s. We want to do a lot for type 2s, but we don't want to leave these poor type 1 kids because there's not enough of them, and it's tough to make a practice out of them over. So the low carb community is doing a good job of looking out for type 1s too.
Thank you, Dr. Dikeman. Can we close the presentation and get Shashi on?
Yes.
I think RD has to close it.
Yeah.
I did.
Yeah. So get me in. Yeah. RD, thank you very much for immediately accepting to come on this conference. I recall
course, for you.
a couple of years back, I approached you for a podcast for D-Life, but that time somehow the timing and date was not.
That's right.
Couldn't get fixed. And finally we met. But I think this topic is so vast that probably will require a much more detailed discussion at a later point. Maybe again, Jasmeet will take your podcast discussion in our D-Life, make it a little more stretchy, and Anup will also be there because he is our masters in insulin in D-Life forum.
Dikeman, she has handled type 1 and LADA cases. And if any cases come to us, we prefer to, let that case be handled by her.
Yeah, with the help of Anup Singh, of course.
Okay.
So thank you.